Dr. Todi, what are the drawbacks of using empirical therapy in Indian ICUs?
The drawback of empirical therapy because of the high incidence of drug resistance bacteria that we have in our ICU. As opposed to the West, if someone is not responding to carbapenem, for example, the chances of fungal infection becomes very high. In our ICUs, if someone is not responding to carbapenem, they might have Acinetobacter, which is carbapenem resistant, and equally they might have fungal disease. So that becomes a very big dilemma that we face almost every day, and that is why sometimes we overuse antifungal along with antibiotics, because we don't have very good markers of diagnosing fungal infection. So, but if a patient is very sick and we have to look for colonization with Candida, I think this is very, very important. All the previous specimen needs to be looked at, whether the patient is colonized with Candida at multiple sites, and is there a focus of sepsis. If there is a focus of sepsis, the chance of bacterial infection becomes very high than fungal. There has been studies on procalcitonin, and low procalcitonin has got a very high positive predictive value for fungemia as opposed to bacteremia. If a patient has a high procal and is not responding to the conventional antibiotic and his procalcitonin is going up, the chances are very high he has a drug resistant bacterial infection rather than fungal infection, because in fungal infection for some reason the procalcitonin do not go very high.
No, suppose the procalcitonin is going down and the patient is not well. So
the
then probably fungal infection could be there.
Low procalcitonin has got a high positive predictor.
You know, the other thing is the echinocandins being an expensive drug, and is there a role of de-escalation with azoles in certain patients who are stable now being discharged?
You know, we can only de-escalate if we have culture positive. So we know exactly what the fungus is. So that's why it becomes so important to send adequate blood cultures when we start empirical therapy, because that will give us an opportunity to de-escalate. Sometimes because of cost, we do not send blood cultures, 2 or 3 sets of blood cultures, but we don't realize if we get a blood culture positivity of an azole sensitive Candida, we can de-escalate on day 4. So the patient is